Hello everybody, I am Ahmed Ibrahim. I am from Sudan, a lecturer in the Faculty of Dentistry, the University of Khartoum. Actually, it's an honor to present to you a brief talk on toombak diverse lesion. These lesions plays a major role in the development of oral cancer in Sudan. I would start talking in general oral cancer in Sudan, and then I will talk in potentially malignant disorders, in particular snuff diverse lesions and toombak diverse lesions as part of these snuff diverse lesions, and I would conclude with the management. So oral cancer is a part of group commonly referred to head and neck cancers, and it represents about 85% of this group. Oral cancer is considered as the sixth leading cause of cancer deaths worldwide and the fifth most common cancer type. Oral cancer comprises about 9% of the annually reported cases in Africa. Squamous cell carcinoma is the main histological variant, as it accounts for about 95% of all reported cases. It can occur at different sites of the oral cavity as well as the oropharyngeal subsites. As shown in this image, the oral cavity subsides in the red highlight and the oropharyngeal subside in the blue highlight. Then let's talk about oral cancer in Sudan. Sudan is a country located in the northeast of Africa. Sudan is a country with multi-ethnicity. That means people are with different colors and culture as well as different habits. In Sudan, the literature review on the epidemiology of oral cancer clarified the conflicting the majority of oral cancer patients present with advanced disease with a percent of 83, and this is referred to as diagnostic delay, which is a prominent feature in Sudanese oral cancer patient. So the diagnostic delay is a responsibility of the patients themselves as well as the medical professionals. So for the patients delay, which is about 73%, and this is because of their lack of knowledge about the oral cancer signs and symptoms, and because of the poor access to the healthcare services and financial problems. Many of those patients consult local healers or herbal therapy. Other factors like fear of the cancer itself and family problems and life events. Here are some clinical photos for patients presented with a very late stage. The second cause behind the very late presentation, or what I meant by diagnostic delay, is a medical professionals, which is responsible for over quarter of the diagnostic delay. And those medical professionals may lack the knowledge or may have low index of suspicion. And here is an example for a patient being treated for actually empirically for tuberculosis, and on our examination, in particular the oral cavity, we diagnosed him with a biopsy as a frank case of CA tongue or oral squamous cell carcinoma, particular of the tongue. So this is or this lead us to know about the clinical presentation or to study the clinical presentation of oral cancer in Sudan or general. So oral cancer has varied clinical presentation. Early carcinomas often go unnoticed because they are asymptomatic, and later in larger lesions, pain symptoms may vary from mild discomfort to severe pain according to the lesion site. Other early manifestations may include mucosal changes in a form of leukoplakias, erythroplakias, or combined of these lesions, as shown in the images below, which are linked to snuff dipping in Sudan. Here is another example of snuff dipping related cancer. Also, an ulcerated exophytic growth or indurated lesions are another example of cancer presentation among our patient, as shown on these images. In Sudan, most oral cancer patients present with an exophytic ulcerated mass in the inner side of the lower lip. We call it gingivolabial, and this name was proposed by Professor Ahmed Suleiman to be as one of the WTO ICDs. It is because of site of dipping. I mean, cancer developed from the site of toombak dipping, which is gingival and labial, in the labial pouch. Here is another example for a very late presentation of oral cancer in Sudan. The etiology of oral cancer. The process of carcinogenesis is mediated by many carcinogens. These include modifiable and non-modifiable risk factors for oral cancer, such as tobacco. Tobacco is the most common extrinsic factor associated with an increased risk of oral squamous cell carcinoma. Many studies confirm that Sudanese toombak is a major risk factor for oral cancer development in Sudan. Toombak itself is a local form of Sudanese smokeless tobacco. It was introduced in Sudan more than 400 years ago. It is considered to play a major role in oral cancer development at the site of dipping, which, as I said, we call it gingivolabial site. The concentration of tobacco-specific nitrosamine is at least 100-fold higher than that of the American and Swedish commercial smokeless tobacco. These photos showing the local form of smokeless tobacco, which is toombak, in comparison to that as the bottom, on the right bottom, the Swedish one. The habit is widely practiced even in young population, as shown in these photos below, which was taken from the east and west of Sudan. Alcohol is another cause of oral cancer in Sudan. Alcohol consumption is a major risk factor for head and neck and esophageal, liver, and colorectal cancer. Alcohol enhances the activation of procarcinogens present in tobacco and also acts as a solvent for tobacco carcinogens, suggesting a synergistic effect in oral cancer development. These photos on right, the first and second from the right, are local forms of alcohol. Other possible risk factors which are in urgent research areas, like dietary deficiencies, infections, either viral or fungal, excessive exposure to sunlight or radiation, immune suppression, and familial or genetic predisposition. Now we can go to toombak dippers lesion as a part of potentially malignant disorders. So potentially malignant disorders, the critical thing about these lesions is their ability to develop into frank oral cancer. These lesions have been called potentially malignant because of the following evidence. These lesions are seen coexisting in the margins of malignant lesions like squamous cell carcinomas. They are also showed malignant transformation on follow-up. These lesions show both clinical and cytological alterations that are showed by squamous cell carcinoma, and some molecular alterations, chromosomal and genomic, are also found in these lesions and malignant ones. The most commonly encountered oral potentially malignant disorders is oral leukoplakia. So, irrespective of whether some leukoplakias eventually progress to cancer or not, most of these lesions arise secondary to the use of tobacco, alcohol, and butyl quid, while the term idiopathic leukoplakias is reserved for a few of these lesions that are thought to be genetically destined. The presence of dysplasia alone in potentially malignant disorder is not an indicator for the development of cancer. Paradoxically, its absence doesn't exclude the development of malignancy either. As the genetic changes precede the phenotypic change, the progress in the prevention and treatment of oral potentially malignant disorders necessitate a good understanding of the underlying molecular events of carcinogens. Snuff dippers lesions. The term snuff dippers lesions have been recommended as an alternative term to other ones such as snuff-induced leukoplakia. Hyperkeratinization and white patches at the dipping site are oral mucosal changes due to the snuff dipping, which occur few months after the use, and they are also reversible after cessation of snuff dipping habit. Other changes such as discoloration, abrasion, cervical erosion, deterioration of the periodontal health, and localized gingival recession may also be seen on snuff dippers patients. The smokeless tobacco products related mucosal changes are of different clinical presentations, ranging from wrinkling to discoloration with different thickening. The intensity of these lesions are dependent on many factors, like the composition of the snuff itself, intervals of the quid, the time duration of the quid, and the years of snuffing. Clinically, these lesions can be classified into 4-point scale of clinical presentations, ranging from wrinkling, thickening to different color changes. In a Swedish studies carried by Axel and his colleague in the year 1976, they classified the mucosal changes among snuff dippers patients into a 4-point scale as follows. Degree 1 represents a superficial lesion with a color similar to the surrounding mucosa with a slight wrinkling. They had degree 2, which represents a superficial whitish or yellowish lesion with wrinkling. So both degree 1 and 2 had no obvious thickening. Degree 3 represents a whitish yellowish to brown wrinkled lesion with intervening furrows of normal color with obvious thickening. Degree 4 represents a marked white yellowish to brown and heavily wrinkled lesion with intervening deep and reddened furrows and or heavily thickening. Toombak dippers lesions. We need to know that the variation in the snuff-induced carcinogenesis among geographical regions is quite dependent on the chemical composition of the snuff itself, and the most common carcinogenic component in which is tobacco-specific N-nitrosamine. Toombak is considered as one of the risk factors for oral cancer development in Sudan. Dafalla and Suleiman in the year 2015 reported 5 clinical presentations which is a 5-point scale like that of the Swedish study of mucosal changes related to snuff dipping. Their project was time impact on clinical pathological changes in oral mucosa of toombak users. They reported a 5-point scale in comparison to a 4-point scale of Axel and his colleague in Sweden. So they had degree 1, which is superficial lesion in a form of slight wrinkling with or without slight discoloration as shown in the image below. And for degree 2, brownish discoloration, cafe au lait like discoloration as shown in the image below. So this is what we believe in toombak related cancer clinical progress. What I mean by that is a cancer development in different colors and mucosal changes from degree 1 to degree 5 into a frank cancer. So this is degree 1, degree 2, degree 3, 4, 5 and a frank cancer. So the aim behind these kinds of studies, the Swedish and the Sudanese, is discriminating lesions from which special efforts should be undertaken to encourage the patient stop or change the snuff dipping habit, and for selecting patients in whom regular clinical follow-up is indicated and when the biopsy is missed. This leads us to a diagnostic procedure. Before taking a biopsy, elimination of a possible causative factor followed by an observation period of 2 to 4 weeks for a possible regression or disappearance of a white lesion is advisable. Then biopsy is a gold standard to rule out malignancy. There are other screening and diagnostic aids. Despite an easy access to the oral cavity, it is often difficult to determine the site for biopsy, especially for more extensive lesions for potentially malignant disorders. Many of the screening aids for potentially malignant disorders are now available commercially, but conventional oral examination is always must. Other aids like staining techniques like toluidine blue, methylene blue and logos iodine as shown in the below image. Another diagnostic aid is brush biopsy, light detection system, VisiLight, and tissue autofluorescence bellscope as shown in the picture on the top. Salivary biomarker. Despite the extensive research in the field of salivary biomarker, not a single biomarker has yet been established for routine use in clinical practice for early detection of oral cancer in oral leukoplakia. So there is no consensus regarding the most appropriate treatment for oral leukoplakias, but the management is always involved the preventive measures, conservative measures and invasive measures. Preventive treatment. So the primary prevention activities like cessation of habits associated with the use of tobacco and alcohol is in all its forms. Restriction for the production, sale and usage. Public awareness and health education programs. Maintenance of good oral hygiene and diet fortified with protein, carbohydrates, fat, vitamins and fruits go a long way in prevention of leukoplakia. Then we can go to the conservative treatment, which is removal of any source of irritation to the buccal mucosa or any mucosal site. Chemo prevention programs may be useful but remains primarily experimental. Local and systemic chemopreventive agents such as vitamin A and retinoids, systemic beta carotene, ketorolic as mouthwashes. Then the surgical treatment, complete excision. The surgical treatment can use conventional surgery or laser ablation, electrocauterization, or cryosurgery. However, this treatment modality does not lower the risk of subsequent malignant transformation and the recurrence. A surgical treatment is recommended in the presence of moderate to severe epithelial dysplasia. However, excision of low risk oral leukoplakias depends on the location, size, and the case of smokers, patient's engagement in smoking cessation. Complete excision of the leukoplakic patch followed by histopathologic examination is the most commonly performed procedure for all lesions. All oral leukoplakias should be undergo a lifetime follow-up at regular intervals, which may range from 3 to 6 months for high-risk lesions and 6 to 12 months for low-risk regions. Thank you, and I wish you a good day.